setting up the meeting. Yes, we are live and we'll be made alive by Madam's presentation. Right. So we will resume the Zoom. So everyone Zoom on Madam. Right. And enjoy the presentation. Yes, ma'am.
Yes, sir. Good evening, sir, and good evening, all the participants who all are here. As we are moving towards the shoulder joint, yesterday we have covered our cervical spine, and now that how the cervical spine versus we are moving, because how we can easily say that whenever the patient with the shoulder joint, we always assess the cervical spine also. So because of this, first we have covered our cervical spine, so that is the trunk of our body, like the spine. So how the connectivity of upper extremity or the lower extremity to the spine influence the dysfunction or disorder of that particular region. So if we want to treat our shoulder patient, so before going as a clinical part, it is always be important that we should be very much clear about the anatomical part, because if we know the surface landmarking, then we can easily understand the patient problem, where they are going to tell us that at this point or at this moment, as a part of the biomechanics, I am having a pain. So if I am clear in that part, then I can easily correlate with that. Yes, this is the way this mechanism, this pathomechanics of this structure can lead to this disorder. So this is the way we always work on the direction in the patient better recovery. So as we are moving toward the shoulder joint, all the physiotherapists, as a part of our learning in a BPT circular or whatever the topics, whenever we are start our anatomy books, we always start with the shoulder joint. So it is a very much more flexible joint, more movable joint in the for the upper extremity, or as we are moving in the lower extremity, that time also our upper extremity, our shoulder joint moves simultaneously while our walking. So it means if there is a dysfunction or disorder in the lower extremity, it can also affect the upper extremity, also the shoulder joint also, as the part of the full relation of the myokinetic and kinematic chains. So today we will see first as a part of anatomy and then biomechanics, how we correlate all these things with our understanding. As normally when we see towards the shoulder joint, we normally see that this is the scapula, this is the clavicle, and how the scapula is attached to the clavicle, then how the bone, the humerus, it is coming and it is related to the movement with the scapula or with the clavicle. So these things we normally see as a part of our learning. But when we move towards the patient, we cannot say that only these three movements we will only going to assess. We are having again the view of, as we discussed yesterday, that structural versus functional versus regional, that will always be our following protocol, where we assess all these things also. So today in the shoulder anatomy, we all very much familiar about all these part of our shoulder, that you can see that this is the scapula, which we can understand that when we will move the our hand in the abduction or maybe in the flexion or in the extension, so that time the role of the scapula will be very very clear as a part of the kinematics, that is the joint. But as the kinematic part, the muscles which are attached to the shoulder joint with the movement of the scapula, that will also be the part of our assessment as a part of kinetic. That's why we always focus not only the just only the kinematics of that particular area. We always see that how the kinetic and kinematic influencing each other. So in this, we know that the shoulder joint, there is a one bone which is attached to the sternum, that is the clavicle. So it means again we have to see that as a part of the visceral, if there is a anything related to the sternum, it is because sternum is attached to the clavicle, and again the clavicle is going to attach to the shoulder joint. So there can be the connectivity of the patient problem also as the part of the ligaments or as the part of the joint. So this is the clavicle, and how the scapula is coming, and this is the humerus, which is also we see that the movement as a adduction, abduction, all the movements which we will see, they all are attached with the uh, all the joints are attached as their articulation, like the sternoclavicular joint, and this is the acromoclavicular joint and the glenohumeral joint. So these articulation is the main focus of the shoulder joint as per the bone, and the ligaments also attached with all the bones, the all the ligaments attached, acromoclavicular ligaments, glenohumeral ligaments, all these are coracoacromion ligaments, they all are attached, and there is a cavity, that is the labrum, in which this bone, when it moves, it sits on this labrum. So this is the cavity where it holds the movement of that bone. So these are the things as a part of the anatomy we always measure in our shoulder anatomy. And in this also, the as a part of the muscles, we are very much familiar that the muscles that is known as the rotator cuff muscle, which is just like the sits, we say that what is the sits, that sub supras subscapularis, which is the coming from behind, and that is then after that the infra spinatus, teres minor. So these and supraspinatus, which is super. This is super. So this is the supraspinatus. Subscapularis, it is down. That's why we are using the sub, and then the infra and the teres minor. So these muscles are very much important part of the rotator cuff, because if there is some injury related to the rotator cuff muscle, that will also restrict the range of motion of the patient, so they will not able to lift their hand in the direction where that muscle which is coming from the rotator cuff is going to use, either internally rotated, externally rotated, medial laterally rotated muscle, or the abductor muscle or adductor muscle. So these are muscles, because whenever we see the patient, we first see that the rotator cuff muscle injury, we check the muscle strength, we check according to that particular muscle's movement, and then we see there is a pectoralis group of the muscles which are also plays a major role for the movement of the shoulder. Also these muscles are known for the breathing, because they are also attached towards the ribs also. So these are the things, it means the patient who are having a breathing problem, again we are moving towards the visceral, if they are having some breathing problem, they are having a pulmonary problem, so it means that muscles will be in that tightening position, that will also restrict the shoulder movement. So these are the things we have to correlate with the somatic versus visceral also. And the deltoid muscle, which is the long lever muscle, which is also provide the abduction to the shoulder. So that is also very much familiar in shoulder assessment. And also the muscles trapezius, which is coming from the occiput, and it is also going towards the shoulder also, and for the elevation of the shoulder, depression or retraction of the shoulder, there are three fibers of the trapezius muscle. So it means this muscle is also very very important, and not only this muscle, the muscles which are related in our the cervical spine, the flexors which are that is also attached, they are also responsible, and all the muscles which are related to the gastric muscles or the hyoid muscles, they will also be the part of our assessment, because as they are also attaching here, and also the ribs, the muscles which are attached to the ribs, so that will be also like the scalenus muscles, and also the sternocleidomastoid, which is also in the anteriorly, because it is also attached to the sternum. So these are the muscles which will be the part of our assessment whenever we see the shoulder patient. So this is not a single anatomy which we are going to follow it. As a part of our AMPT, we always follow all the protocol where we see that what kind of the either the kinetic or the kinematic which is going to be checked in which direction will give us the idea, which will give us the clue to treat our patient. So this is very important part here as a part of myofascial component. And this is the articulation of the shoulder joint. Yes, it is also very, very important part of our understanding that this is the clavicle and this is the glenoid cavity and this is the humeral head. So the round head of the humerus and the shallow pear shaped of this glenoid cavity which is attached to the scapula is our movement, like this is the cavity and how this is the humerus, so how it will move, that will be the major part of our assessment, because it is moving in the direction. And this glenoid cavity, this is the concave bone and this humerus is the convex bone, so how their articulation will take place according to the concave and the convex rule, so that will also is our assessment of the part, that which glide is restricted, in which direction the patient needs the treatment. So that is also very important, because this is the convex. So how it is moving? So it is moving superiorly. So the gliding is inferiorly. So this is the way, because this is convex and this is the convex concave. So if it will move, the both the glide and the rolling will be in the same direction. So this articulation of shoulder joint is also very important part of our assessment, because patient is having a problem relating to the range of motion restriction. So sometimes some patient, they are not able to abduct their hand, so they are feeling pain when they are abducting. So there are also, as a way of pathomechanics, so many things which restrict the shoulder abduction. That is also as a part of kinetic and kinematic. And also the some patient, they with the internal rotation and external rotation restricted, that is also the articulation is very very important part here. And also the dominating versus the non-dominating hand, that is also very important. Either the patient is having a shoulder related problem in their dominating hand or in the non-dominant hand. So this is also with the articulation, we check all these movement also as a part of our assessment. And this is the glenoid labrum. You can see it there, that this is, as we have seen, that this is the glenoid labrum, the articular surface which is covered with the hyaline cartilage and the glenoid cavity. It is dependent by the presence of the fibrocartilaginous. This is the synovial sheath and the fibrocartilaginous sheath, which is known as the glenoid labrum. And in this also you can see that at the pointing this, there are some points which has shown that how the insertions of that particular point, that the long head of bicep tendon, superior glenohumeral ligaments, then there is a joint capsule, medial glenohumeral ligament, inferior glenohumeral ligament. This is the axillary pouch where the axilla we check with the hand. And this is also the posterior band of inferior glenohumeral ligament, because these ligaments gives the stability to the shoulder joint. If these ligaments are in the instability, there is a laxity, the tissues are laxate, so that time this the movement will be, because the patient will pain when the movement is going on according to the position. And in this also I will say, it is not say we can easily not check all these things that which ligament is not working. For this also, as a part of the pathomechanics, in which degree of the movement we check these ligaments, superior, medial and inferior, in that degree of movement we check, and then we can say that either this is the superior or this is the inferior or this is the medial ligaments which is not which is in the instability. And then we are moving towards the insertion of the teres minor muscle, which is as a part of the rotator cuff. Then infraspinatus, that is also the part of the rotator cuff. Then this is the labrum where this cavity is there, and this is the supraspinatus which is in the superior, because this is superiorly and this is give the movement of the shoulder abduction. So it means that there are something very much important in supraspinatus, because here are the bursa, here are the tendons which are going to insert. So if there is a problem in this space, so it will create a narrow space for the supraspinatus. So definitely the shoulder abduction will be restricted. So very very clearly we have to notice all the movement, and how we can assess in the movement the direction of that particular movement of that particular part of this ligament which is attached to the glenoid labrum. And the type of the joint, we know that which kind of the type of this joint is the ball and socket joint. It is fully with the synovial. So there is a synovial sheath in this synovial because fluid is there. So because if the patient who there is a thickening of that particular fluid, synovial fluid, after that thickening, like the patient who are the diabetic patient, so there the because of the thickening of that synovial fluid, their movement is going towards in the restriction. So that time this cavity, that the humeral head will not get more space for the movement, and that already there is a thickening, so that less movement will come and the patient feel the pain. So in this also, this ball and socket movement is very important as the movement, because it gives the degree of freedom to move the humeral head. But if the cavity is having a less space, so there may be chances of the dislocation also, there may be chances of the subluxation also, and after that the patient get feel in their particular direction of the movement. And this is the fibrous capsules surrounds the joint that is attached medially to the margin of the glenoid cavity outside of the labrum laterally to the anatomical neck of the humerus. So this is the anatomical neck of the humerus. This is the glenoid cavity, and how these the ligaments which plays a very major role, that is the coracohumeral ligament transfer. This is the transfer humeral ligament which is inside the humerus. So this kind of the situation, this is inside the transverse humerus, and here are the ligaments which are attached in the fiber with the superior, middle and inferior glenohumeral, which is mentioned in this way that you can see that with the different colors. So these are the ligaments which are attached to the labrum, so with the capsules. So these ligaments plays a very much important role in the stability. So this capsule is thin and lax and allowing the wide range of the movement because of the surrounding with the ligament, like with the superior, middle and the inferior GH ligament, and this is the folded capsule which is inferiorly. So these ligaments of this with the labrum with the capsule provides the stability of that particular joint and their movement also. So if in this ligaments are in the instability form, it will not, either they will be hyper mobility will become, so the patient will be feel pain, or maybe hypomobility as a thickening of the capsule, so the patient will be feel pain. So in this also, this direction as a part of dislocation and subluxation also come in our mind whenever we see this kind of the situation of the instability kind of disorder. So that will also give us the idea that why the patient is not able to move their hand in the particular direction. And this is the synovial membrane. It is also attached with the capsule, and these are the ligaments which are very much important for the movement of the shoulder, because this is the clavicle, and these are the ligaments which are attached with the coracoid process to the acromial. So these are the ligaments, namely they are known as the trapezoid and the conoid ligaments, which is the part of the clavicular ligament. So these are also provide the stability when the shoulder joint is moved, because they are attached with the coracoid process to the acromion. So in between they are the ligaments which are attached. So if this ligaments, there are the problem related to these ligaments, or any injury, any fall after that, these ligaments will torn, so that also the patient movement will be restricted. So this is also very important when we see that there is a thickening of the synovial membrane, and that time also these ligaments will not move properly in the direction where they want to move. And there are also the bursas which are present, they will also give the friction for the movement, so that will also create a pain while doing the movement. And there are nerve supplies, that is also very important part of the shoulder, because as a part of our shoulder joint, the cervical spine, which we have seen in our yesterday session, that how these nerves play a very important role in our understanding. Like we know that that's a brachial plexus which is coming from the spine till the shoulder, and after that the muscles which are nerves which are going towards the upper extremity, that also provide the movement of that shoulder joint with the muscles which are internal rotator, which are external rotator, or the anterior capsule, posterior capsule. So according to that, which provides the external rotation and internal rotation, so that time the muscles, like with the anterior capsule, we provide the external rotation. So there the median nerve is going towards the shoulder. So that will be influenced. And if there is a posterior capsule tight and internal rotation is restricted, so there the movement is the supply with the radial nerve. So that will be the cause, maybe the neural component, that radial nerve is in our mind to treat our patient. And also the subscapularis nerves which are also supplying towards the scapula also, that can be axillary nerve, that can be. So these are the nerves which are related, which are supplying according to the brachial and the cervical plexus, can be the assessment part of our neural component, which we will check it whenever we see the neural component, because we know that articular component as a part of our understanding, myofascial where the rotator cuff, and also the muscles which are attached to the shoulder movement anteriorly, posteriorly, or also posteriorly the latissimus dorsi or the thoracolumbar fascia. So they are also attached. So we have to see all these muscle, because there is a chain, full chain is coming towards the posteriorly or the anteriorly. That is also the part of our assessment as a part of kinetic and kinematic. And then we will move towards the movements of the shoulder. That is also very important part. In this also we divide it in the two parts, that is orthokinematics, where the movement of the joints or the bones, like the osteokinematics means the movement of the bones, and the arthrokinematics the movements of the joints, which is also very much important part here, because we have to see that when the bone is moving, how the joint is moving. So these kind of like the rolling, spinning, and the gliding, it is the movement of that particular joint. So how they are in the rolling position, like in the rotatory movement, one bone is rolling on the another bone. A spin is a rotatory movement where the one body is spinning on another body, and the slide is a translatory movements, which sliding on the one joint surface on another. So we have to check this movement also as a part of our orthokinematics. And then the osteokinematics, these movements we can see from the outsides, because they are the movement of our bones. Like the arthrokinematics, they were the movement, the joints which are going, which are not visible, but we feel that how we check with the assessment. But these movements, like the flexion of the arm, extension, abduction, adduction, lateral rotation, medial rotation, so these are the movements osteokinematics which we can see. And this is the main our focus which we see in our patient, that how these movements are in the restriction, how the range of motion is restriction in the shoulder joint. And then we see the possible movements, that how the flexion, extension, abduction, adduction, or also the circumduction. So that is also the part, because this whenever we see the shoulder joint, and this is the ball and socket joint, so the full circumduction we check it, that either this movement, this is restricted, or it is coming till this. So how much degree of movement is coming, that is also very important. Like the flexion we see in the anteriorly, extension, and with the circumduction also. So these are the possible movements which we notice as a part of our active and the passive assessment of the shoulder joint. Because in this it is important to check the end feel, either this end feel is the bony end feel, either this end feel is the myofascial end feel. So or it is a just restriction, the patient is not able to move actively, and passively we can take it at one point. So that is also the differentiation of active versus passive testing is very much important for the shoulder joint. And this is the muscles, which are the muscles which are responsible for the flexion. That is also important part here, because we know that the flexion, normal flexion is about to 90 degree. So it is performed by the anterior fibers of the, because this is the deltoid muscle, you can see in this picture also, this is the deltoid muscle. So their anterior fibers are responsible for the flexion movement, because they are anteriorly. And the pectoralis major muscle, which is attached with our with the chest muscles, and the biceps brachii, that is also, because we know that the bicep group of the muscle, so that bicep brachii, that is also for the flexion. And the coracobrachialis, because this is also attached to the coracoid process, so that is also the flexor of our hand, arm. So that is also for mainly for the flexion. So if this muscle is tight at the their origin to insertion, as a part of the insertion which is going into the radial head. So if this muscle from origin to insertion at any point it is in the tightening position, it is in the shortening position, so that will also restrict the shoulder flexion. So these are the things, we are not only working at that particular this area, or we are not going to assess that only that area. So we have to see that the what muscles are going coming, and that what muscles are inserting, and what muscles are the origin. So that is also important part, to check all these muscles which are coming and taking the part of initiation of the flexion movement. So that we also check as a part of the deltoid anterior fibers, pectoralis major, bicep brachii, and the coracobrachialis. So these muscles which is attached to the shoulder joint. And then we see the extension. So the normal extension is about 45 degree, because flexion movement is more than the flexion is the more than the extension. So that is the 45 degree which we are taking towards the back. So this is the extension, and it is performed by the posterior fiber. Like the flexion was with the anterior fiber, and the extension with the posterior fibers of the deltoid muscle. So that will work. And also the muscle which is the latissimus dorsi, you can see it here, that is also attached for the extension, and the teres major muscle also. So these muscles, and this is the trapezius. So these muscles are also plays a very major role when we do the shoulder extension. We are doing the possible movement of the extension. So if the extension is restricted, so that time also we should be very much clear that we have to work on these muscles. By checking the muscle strength testing of these muscle, we can assess that either there is a muscle is in the tightness, maybe the fascia is restricted. That's why we say that yes, what is the role of the fascia? Because if there is a fascia is in the contracture, if there is a fascia is in the tightening, so that time folding the fascia, if the fascia is folded, so how we unfold the fascia with the muscle contraction, that is also a part of our assessment, evaluation, treatment according to the AOMPT, that we work on the fasciomuscular release, where we work simultaneously, we work on the muscle also, and we work on the fascia also. So that's why we provide the more range of motion to that particular area where it was restricted. And this is the muscle for the abduction, which is very much the patient who are having the shoulder pain, they are having a problem related to the shoulder abduction. So that is their major problem. They are not able to take their hand, and they just say that after that I am not able to take it. So that abduction is restricted. So this is the upper limb, the both the joints, the shoulder joints, we see that between the scapula and the thoracic always we doing, because as from our childhood we do the exercises in our school, the PT exercises. So there we do the shoulder abduction from both the hands. So that time we know that this is the scapula movement is also like the winging of the scapula is going on, and also the thoracic wall, that is also if there is a dysfunction related to the, there is a some thoracic spine related problem, so it means that they will also restrict this movement. And also the trapezius fibers of the middle and the lower fiber of the trapezius, or also the muscles which are posteriorly like rhomboid muscles, serratus anterior muscles. So these will be also play a major role as a part of the shoulder abduction restriction. So in this also the supraspinatus is mainly the muscles which we check it with the shoulder abduction, and also the deltoid, which is also the long lever muscle, which is also take part in the shoulder abduction. So these two things as a part of our supraspinatus and the deltoid muscles that we check, and also the muscles which are related to the scapula, that will also play a major role, because as we can see it that how that we will doing the movement, so that time how this scapula is moving, so that time these muscles which are attached to the scapula, like the muscles which are attached, which are for the elevating the scapula, so maybe they can be the trigger point in that muscle, like the levator scapula, which used to lifting the scapula. So that can be also the cause. So that's why the patient having the shoulder problem, they are having the restriction in the scapular region. So that is also important part of our assessment. And this is also that you can see that supraspinatus, it initiate the movement of the abduction from 0 to 19 degree, and the holds the head of the humerus against the uh, glenoid fossa, because this is taking it and it is holding into the cavity, the humerus head into the cavity. So the later function of the supraspinatus allow the deltoid muscle. After that, the first the supraspinatus work. After that, the deltoid muscle will take over, and it will contract and abduct the humerus at the shoulder joint. So these both muscles, they both work as a friends with each other. So if there is a one is not working, so other will take over, but it is depends upon that how the cavity is allowing to the head of the humerus to move, then the kinematic, and after that the role of the kinetic, the active participant of that particular muscles, which are the shoulder abductors, so they will take place in that area. And the muscle which are for the adduction is towards the body, we are taking the movement towards the body. So these muscles which are normally as a part of the upper limb can swing with the towards the chest. These are the muscles which are pectoralis group of muscle, latissimus dorsi, which you can see it in this picture that how it is attached. So they are the muscle for the adduction, teres major and minor, and these both, because teres major and the minor, they both are in the posteriorly, so they will take it towards the towards the chest. So these muscle, and also the latissimus dorsi, which is also attached to the spine, and it is also taking it in the medial direction, and pectoralis major muscle, that is also for the adduction. So these muscle plays a very, very major role. So if we have to check according to that particular muscle, in which direction these muscles are going to work, according to that we can release or we can strengthen that muscle by giving the exercises, that is the part of our functional training. And this is the muscles which are for the lateral rotation, like we are doing the hand in the lateral rotation. So this is the lateral rotation, because the normal lateral rotation is about to 40 to 45 degree, which is name mainly performed by the infraspinatus muscle, which is the part of our rotator cuff muscle, and the teres minor. So these both muscles are the lateral rotators and the posterior fibers of the deltoid, because the posteriorly the deltoid muscle, so they will also take the part in the rotation, lateral rotation. So infraspinatus, teres minor, they are the rotator cuff muscle which provides the lateral rotation. And there are muscles which are the medial rotation. So the subscapulary, which is towards which is below the scapula, that's his name, itself tell us that this is in the downwards position, which we check in the axillary area, we check the trigger point in for the subscapulary. So they are the internal rotator, because they are medially rotating the arm. So these muscles, if there is a trigger point, if there is a shortening in this muscle, so they will restrict the internal rotation also. So the patient who are having a shoulder, frozen shoulder or impingement, or they are not able to do internal rotation, so that time as for the shoulder abduction, our mind click the for the supraspinatus. So same like when we check the internal rotation, then the first muscle which is comes in our mind, that is the subscapulary. So treating that muscle is also a very, very important part for treating the patient who are having a shoulder problem, the patient who are not able to take their hand in their back. So it means the subscapularis is the culprit there. We have to treat that muscle, and also the latissimus dorsi, teres major, and the anterior fiber, because here I am moving my hand there. So this is the anterior fibers. And when I was doing the external rotation, then the posterior fibers were going for the deltoid muscle. So these things, according to the fiber of the muscle, plays a major role. So we cannot say that the patient who are having a frozen shoulder, we will just treat it that area with electrotherapy or the some exercise, pendulum exercise. That's it. We have to see that the which muscles, which fibers are going to engage in that particular movement. So that is our major understanding here as a part of AOMPT. So in this also you can see it very clearly that the how movement of the deltoid versus how that this is the trapezius and this is the serratus anterior, and how the subscapularis, they are taking the movement when we do the movement. So according to with the every movement of the 3 degree of the abduction of the arm, the 2 degree abduction is happening in the shoulder joint, and the 1 degree abduction occurs by the rotation of the scapula. As we are moving, after that that scapula start moving with that. So it means again that if the patient is not taking their hand in the abduction, so we have to correlate with the scapula movement also, that either the scapula, like in this also we assess with the supported position or sitting or lying down supine position or the standing position, because in a supine position patient easily take their hand in the abduction and in the flexion. But when we do check in the standing position, that time they feel no, because that time the scapula is not getting the support in that direction. So that scapula movement is restricted. So how the movement of the with the laterally movement of the scapula will provide the shoulder abduction, that is our part of the understanding that about 120 degree of abduction of the arm, the greater tuberosity of the humerus moving, and then the lateral border we check with the thoracoacromial arch, that is also moving, and then the scapula is taking towards the upward direction. So this is also that abduction involved rotation of the scapula also, as well as the movement of the shoulder joint also. So the assessment of the scapula is also very, very important to check your shoulder joint. And this is also, you can see it in this picture very, very clearly, that how these muscles, the supraspinatus, deltoid, trapezius, and the serratus anterior. So they are with the moving the muscle in the scapular mechanism, how these muscles are moving. Like from this is the movement, then this was the in the downwards, and the deltoid has taken the place. And this time that serratus anterior, that is also involved in the picture. And when we are going towards the overhead, so how the mechanism of this deltoid to the supraspinatus muscle. So they have maintained the shoulder abduction, and also the clavicle with their the trapezius is attached. So that is also because that is the first fiber of the trapezius, superior fiber. They also elevate the shoulder joint. So it means they are also working together. So these muscles, that's why as a part of cervical spine or as a part of the shoulder treatment, we see the trigger point in the upper trapezius. So it means that there may be tightening in the trapezius also. So because of that, the patient is having a pain with the shoulder movement. They are having a pain in the upper trapezius also, because there are active trigger points which we never check in that position. We just focus on the shoulder, and that just check it. We forget that the mechanism of the scapula, we forget the mechanism of that particular muscle which are also attached there, and also that the muscles which are coming from the spine, that will also give provide as a part of the facial movement. So the facial gliding is restricted, so the patient is not able to lift the hand. So that's why it's a the comprehension picture of muscle, fascia, joints, ligament, and capsule whole which comes in our picture. So according to that, we see that which is restricting in the patient movement, and where we have to start, and where we have to move with the patient functional recovery. And this is the circumduction, that is also very important part of the movement of the humerus head, because when we do the overhead activity, taking the hand down, here again moving the hand, or the horizontal abduction, so there also that if there is a circumduction which is restricted, so that is because in the circumduction it is formed by the flexion, abduction, extension, and adduction. So all the movement is coming in the circumduction. So if any one movement is restricted, so definitely it will not allow the circumduction of that particular joint. So we have to check all these movement, which movement is not able to provide the completion of the circumduction at which lever, either the flexion or the abduction or the extension or the adduction, because they all four movements are the part of the circumduction. So we have to check full mechanism again in this direction, so that we can check the muscles which are flexors, the muscle which are abductors, the muscle which are adductors, or muscles which are extensors. So we have to work on that particular part, and to provide a better movement which was restricted in my patient. And this is the stability of the shoulder joint, which is completely with the joint is unstable if there is a shallowness of the glenoid fossa and the weak ligament, because all the ligaments, they are supporting, or if there is a tone, the tone of rotator cuff muscle is not full, the strength is less, so also the patient will not able to lift there. That's why we check the drop arm sign, we check with the rotator cuff tear, or we check with the shoulder impingement at the painful arch also. So these the least supported part of the joint, which is in the inferior location, because here no ligament for the support, so where it is unprotected by the muscles also. So these things, that rotator cuff strengthening, ligaments stability, that gives the full picture for the movement of the shoulder joint, because the stability with the ligament, movement with the rotator cuff, they are making the compensatory with each other when the patient is doing their activity. So that is also very important to check, either the drop arm sign is there, or the at a particular arch the patient is not able to perform their hand movement. So that is like a shoulder impingement, because that impingement can be, there are so many causes for impingement also, that we have to check either the impingement is external or internal, that is not allowing the movement, and because of that the painful arch is coming in that particular direction where the bones are rubbing with each other, either, or there is a bursa is inflammatory, so the patient is not able to lift their arm. So these are the things as a part of articular myofascial and as a part of the neural compensation according to the radial versus the median nerve, anterior versus posteriorly, that is also provide the stability of the shoulder joint. Then we are moving towards the pathomechanics, that how we check in which condition the patient is having a problem related to the shoulder joint. That is also our part of understanding, because without understanding of the pathomechanics of any region, we cannot move forward towards the manual therapies. Because if we are not able to find that what mechanics is not working properly at what point, so we cannot provide, because after that we can decide it, we cannot give all the treatment to the all the patient, we cannot give all the techniques simultaneously to the all the way, because as a part of our clinician we have to very much clear that what kind of the treatment my patient needed as a part of the stage of that particular dysfunction or disorder, that if according to that we plan our treatment, either they need the mobilization, either they need the functional training, either they need the myofascial techniques if they are in the spasmic position, if they are in the tightening position. So there are some points which are very much familiar to all the physiotherapists. That is the dislocation of the shoulder joint. So that is the shoulder joint which is commonly dislocated when there is a fall or there is a injury, any traumas, or we slip at that time. So that anterior inferior dislocation we normally see, and after some fracture, that also the cause for the patient the dislocation, because dislocation is that the joint is dislocated from their space, and there are some cases when where the patient is having a subluxation. So subluxation and dislocation, both the terms are different, because in the subluxation the joint moved from that area, but it comes back with the movement, it is coming back, so that is the subluxation, means they will be, the joint is coming back at to their place. But dislocation is like that if there is a humeral head, it is dislocated anteriorly, so it means it is dislocated anteriorly. It is dislocated posteriorly, means it is dislocated posteriorly. But when there is a subluxation, at one moment it will go out, but in another moment it will come out, come in their place. So this is the subluxation. So it can be coming and going like condition. At one point it is going out, but another point it is coming at their place. So that is the subluxation. So this also, the differential diagnosis is very much needed, that either the patient is having a dislocation or they are having the subluxation. So according to that, because if there is a dislocation, so there may be the torn ligaments are there because it is dislocated, or maybe the fracture, because of that fracture of that humeral head can be the cause after the dislocation, or after the fracture there is a dislocation. So these things are also a very important part to understand. And these are, you can see some images where you can see that this is the glenoid process, and this is the anterior shoulder dislocation. The shoulder is dislocated anteriorly, that the humerus is inferior to the coracoid process. This is the coracoid process, and that is inferiorly because the shoulder joint is dislocated anteriorly. And in this picture, you can see that the shoulder joint is dislocated, humerus fixed in, internally rotated, and it is going in the posterior dislocation. So that is in with the internal rotation. When it is going in the anterior dislocation, it will go into the external rotation, and when it will go in the posterior dislocation, it will go in the internal rotation. So these both pictures are telling us the view that how the anterior versus the posterior dislocation, they both are differently in the mode of the action of that particular joint. One here is it is going the external rotation, and another it is going towards the internal rotation. So these are the things that shoulder dislocation, the both the conditions are different as a part of anterior versus posterior dislocation. And you can see it that here, this is the lesions. That lesions are that are commonly seen with the anterior dislocation includes the Hill sachs fracture and the Bankart fracture. So these are the two fractures which we see in our patient. Sometimes the fracture of the humeral head, it occurs as along the posterior and superior aspect and caused by the impaction of the humeral head on the inferior aspect of the glenoid fossa. So this is at the when we see the hill sash fracture, this is the superior side, posteriorly superior side, this is coming, and the bank cart, as a like we see that the bank, so it is downward. So it is the bank cart fracture is downward. The inferior side, it is caused by the same mechanism, but the area is different. It is the inferior aspect, that is the bank cart, and the hill sashes, this is the uh, uh, superior side. It this kind of the fracture comes. So according to that, we see in the dislocations also, because as a part of anterior dislocation, or we see the internal the posterior dislocation. So because of these lesions, because of these fracture, the dislocations are coming, and after that the muscles which are external rotators or internal rotators, these muscle also go uh, went into the tightness, or maybe in the spasm. So according to that, this pathomechanics works, that what is the mechanism of that particular area when it is in the injury, when it is in the fracture. So according to that, their kinematic we match with the kinetic, and then we treat our patient. Not only that they are in the fracture on as a part of posterior or the inferior, we start our treatment. We have to see the mechanism of that particular kinetic part of the muscles, which can be used as a functional recovery, the strengthening of that particular muscle. You can see that this is the hill sash fracture, which is in the superior area of the, you can see it in, and this is the inferior direction. This is the Bankart fracture, and this is the humerus head, and this is the labrum. Bankart lesion occurs in the lower part of the labrum. So this is the labrum. This is the lower part of the labrum. So that you can see it. And this is the rotator cuff tendinitis, because if there is a rotator cuff injury is there is a tendon, because we know that all the rotator cuffs, the muscles which are coming as a part of their tendon inserting into the shoulder joint. So if there is a inflammation in that tendon, so it will also not allowing the shoulder movement. The patient will feel uncomfortable with their shoulder abduction, or maybe the people who do more excessive overhead activity of the upper limb, maybe the tendinitis is the cause of their pain. And because of during abduction of the shoulder joint, the supraspinatus tendon also exposed to the friction with the acromion, because that is also because there are the subacromial bursa is also. So if that bursa is inflamed, because bursa that is providing the cushioning to that particular bone, so if that bursa is inflamed, so it will swelled out. So it will not allow the movement to the tendon to move. So the tendon should be, previously it was moving smoothly, but like the bursa is swelled, so it will give less space to tendon to move. So it means that the tendinitis, the cause can be the friction against the acromion also, or the maybe the subacromial bursa. Because of that, the rotator cuff tendon are not getting their space to move, to keeping the glenohumeral head in the concentric position, the centric position in the cavity. So these are the things which are also very important, that either there is a bursitis, either it is a tendinitis. Because of that, the patient is not able to perform their overhead activity, or maybe the cause, because it is because of some injury, or maybe repetitive movement of that movement. Because of that, the tendons are in the inflammation. And this is also, you can see it, that how the while doing the abduction and adduction, the rupture of the tendon, which is seriously interfere with the normal abduction movement. So the main function, which we know that the supraspinatus muscle which hold the shoulder abduction. So if the patient with the ruptured supraspinatus tendon is unable to initiate the abduction of the arm. So if the arm is passively assisted with the first 15 degree with the abduction, after that the deltoid will take over and complete the movement of the right angle. That's why the patient is not able to perform the shoulder abduction actively, because the shoulder abduction was not assisted with the supraspinatus, because supraspinatus tendons were is inflamed. But as we do passively the movement of the shoulder abduction, so after some degree of movement, the abduction is taking over by the deltoid. So as a therapist, when we do the passively, so that time the patient is able to move, but actively they were not able to move because we have making the force as a passive testing. So that time we are taking with the help of the deltoid long fiber. And this is the subacromial bursitis, supraspinatus tendinitis, or the pericapsulitis. So these are the things where the degeneration changes in the bursa, which is followed by the degenerative changes in the underlying supraspinatus tendon, and they are these tendons which are related to the rotator cuff. So these clinically, these conditions are known as the subacromial bursa. Inflamed bursa is there, so inflamed tendon, inflammation in the tendon itself, so or maybe the thickening of the capsule. Because of that, the patient is not able to move their arm in the shoulder abduction. So three causes which restrict the supraspinatus because of the tendinitis, because of the bursitis. Bursa is the cause, tendon is the cause, or the thickening of the capsule is the cause as a part of the frozen shoulder, or as a part of the subacromial bursitis or supraspinatus tendinitis as a part of the painful arch. So these things are also the shoulder impingement versus the frozen shoulder, where the thickening of the capsule, where the inflammation of the tendon or the inflammation of the bursa, that all is the different view of our assessment, that we check it that why the patient as a part of the bursa, they are not, after that they feel the pain according to their pain point, where they are feeling the pain at with which movement, that is very important for the understanding. Then this is the shoulder impingement, because that shoulder impingement itself, people know the name that when the impingement, that something is impinging. So that is the way that we check with the movement that at which arc the patient is getting the problem in the movement. Like you can see in this picture very clearly that this is the bursa, which is inflamed bursa. So they have taken a more space, so that the space which was coming previously was proper, but now that that inflamed bursa has taken place, so that means that this tendon will not able to move, that bone will, joint will, the clavicle will not move. So this is the supraspinatus muscle which is coming here. So it is getting the compression force because of the inflamed bursa, so that in that area where it is getting stuck, so that this painful arch is the shoulder impingement, because here the tendon is getting impinged, the muscle is getting in the impingement, so the muscle is not moving into the their shoulder abduction, their movement is not coming because of the inflammation of the bursa. So that is the way we check that shoulder impingement itself tell us that the how the painful arch. It is not that the full arch is not, there is a no restriction in the full arch. Patient can take at the one level, but at one level as a part of the, suppose 60° to 120°, the painful arch is there. After that, when they cross the barrier, when they cross the hurdle, after that the hand is moving in the proper movement. So it means that was the hurdle, that was the speed breaker which the shoulder joint has to cross, and after that there is a no barrier for the shoulder movement, and it will automatically move. So that arch, if crossed by the joint, after that there is a no pain to the patient. So it means that we have to check that either the patient is having a problem related to the painful arch, or the problem is related to the rotator cuff. And this also, that painful arch that we have already discussed, that how the pain impingement syndrome suffer with the painful entrapment of the soft tissues whenever they elevate the arm. So this is also the pathological mechanism there, which reduce the space, so restrict the range of the motion. So the if the space is reduced, the range of motion is restricted. That's why the painful arch is coming. So that is known as the shoulder impingement. So in this also, we know that rotator cuff, because not only the joint is moving in that direction, that is also our rotator cuff of group muscle and their tendon are also attached to the upper part of the shoulder. So that's why the patient feel that muscle strength is less. They feel that I'm not able to lift my hand, that my muscles are not working, my muscles are weak, because they are not able to lift and rotate their arms. So it means there is a weakness. The muscles, the rotator cuff muscles, which are responsible for that particular action, and which are the rotator cuff which sit under the bone, that acromion, and they are not getting the space on that area, so the muscles are not, the tendons are not working properly, they are slipping at their place. So if there is a shoulder impingement, our rotator cuff catches the rub under the, against the acromion, because it is coming with the acromion, so it will rub to the acromion, and then the patient will feel the, whenever they will feel the arm, they will feel the pain, because as a space which is covered with the bursa, the fluid, the filled sacs, they are in the inflammation, so they will not allow the rotator cuff and acromion by giving the narrowing, which increase the pressure, and the patient feel pain that time when, and they will feel irritation towards their rotator cuff muscle, either the supraspinatus or the other muscles like the infra and the teres or the subscapularis. So this is the way we understand the mechanism of the shoulder impingement, how the tendon, how the bursa, how the rotator cuff muscles, they are working in shoulder impingement, and after that inflammation they are not working properly, so we have to train according to that, the particular movement of that particular rotator cuff muscle, and then we can treat our patient for the shoulder impingement. So these are some pictures that how we check with the movements, because we know that the painful arch, in which direction the patient feel the pain. So according to that, we check according to the anterior part of the shoulder, posterior part of the shoulder. So according to that, we have to measure all these movement of that particular muscle, as a abductor, as a rotator, medial rotators, lateral rotators, or the muscles according to the extension and the flexion of the muscles which provide to the shoulder joint. And then impingement, it's also there is an internal impingement, which is mainly we see that the internal impingement is in the labrum, the cavity. If there is an impingement, so after that when the bone will be moved, it will be painful in every movement. So that is the labrum tear, or the inferior rotator cuff muscles, or the proximal biceps long head, so there is an impingement, so that is the internally, because they are related to the internal side of the labrum. So, and if there is a external impingement that is coming with the painful arch, that is the like the supraspinatus or subacromial bursa, so they are coming in the external impingement, because as we know that if there is a external impingement, so after crossing the barrier, the pain will be, there will be no pain. But if there is an internal impingement, so it will, with the every movement, it will feel the pain, because there is a, the road is just fully road is in a braking position, there is a pits in the road, so the every time that how the vehicle will be moved, it will become in that it in the jumping position. But if there is a only the external impingement at one point, so that will, after crossing that point, like the speed breaker, or if there is the flattening of the tire, so the every time the movement is painful, because our tire is flattened, so how much we will move, it will feel the pain. But as the our tire is right, but only the hurdle is the speed breaker, so that breaker we cross the hurdle and we will cross it, so that is the painful arch, or that is the internal impingement, where with every movement, with every step, we will feel the pain. And this is the rupture of the supraspinatus tendon. So in some cases, the rotator cuff tendinitis, the necrotic supraspinatus tendon can be calcified or the ruptured. So because of that, if there is a position like rupturing or the more thickening on the supraspinatus, so the patient, the shoulder abduction is really very much painful, and patient will not able to perform their overhead activity. And this is the labrum tear. This is the labrum. If it is tear, so it is a, like we know that the cup shaped rim, so if there is a reinforces the ball and socket joint of the shoulder, so if there is a tearing in the labrum, so the humeral head will not able to move, and every movement will be the painful. So it is clearly that we have to see that either the labrum is in the tearing position, or the pain is because of the tendons or the bursa. And this is the frozen shoulder condition, which is we all know about, that the adhesive capsulitis or the chronic subacromial bursitis. So this is also the painful condition of the shoulder joint, which as a part of clinician, we all physiotherapists, we treat our patient for the frozen shoulder. So here also there are so many things which we have to check as a part of the kinetic and the kinematic, or we have to follow the pathomechanics of that particular joint, that how it takes a time, or either in which stage in our yesterday session itself, that sir has explained that how the frozen shoulder patient we cannot treat with all the techniques. We have to see that in which condition the patient is, either in the first phase of the frozen shoulder, or that is the painful phase, there is a gradual onset of diffuse shoulder pain, or the patient is in the stiffening phase, that is the progressive loss of motion, and the patient lose glenohumeral external rotation, internal rotation, and abduction during this phase. So that is the stiffening phase. So in that position, so how, which kind of the technique of manual therapy we will utilize, as a part of the painful stage, as a part of the stiffening phase, or as a thawing phase where the gradual movement is improving. So this phase also, that how we can give them the neuromuscular functional training in that thawing phase, where the patient is going towards the recovery. So the first stage where the painful phase is there, we cannot give them the articular technique. So that is very important part. There the need of the neural component as part of the internal rotation, external rotation. So which neural component we can add and we can treat, because the nerves which are entering into the muscle at their neuromuscular junction, so that time the neural component adding that condition gives the relief to the patient, the offloading versus the loading of that particular nerve. And in the stiffening phase, where the patient can take some mobilization also, or they need the myofascial release techniques, where to release the fascia with the muscle contraction we can give them a relief. So that is the stiffening phase, because there is a tightening of muscle also, tightening of the joint also. So there, as a part of specific versus gross versus the direct myofascial technique, we as a part of our recovery, as a part of our step by step we can utilize, and simultaneously we can give them some mobilization according to the grading of either the, with the pain versus the restriction, which grade of mobilization the patient need, that we can provide. And after that, when we are moving towards the thawing phase, where the patient is ready to accept the functional exercises, there we can train according to the functional neuromuscular training. That is also, the training is needed very carefully, where we have to train the patient according to the patient situation, in which condition they are, they need the stability factor or the mobility factor. So according to that, as a AMPT approach, we work on the stabilizer, then we work on the mobilizer. That is our priority here as a part of our patient centered approach. So don't think that the frozen shoulder exercises, all the exercises for all the patient who are having a frozen shoulder, that is the cross mark in the AMPT. We work according to the relieving factor of the patient. According to that, we select our exercises. We select our treatment according to the patient condition, according to their daily activity, their daily profile, that what kind of the patient is sports person, the patient is sedentary lifestyle, the patient is the homemaker. So what is their preference, which kind of the movement they want, their priority. So according to that, we provide our treatment. So this is the beauty of AMPT. We never forced the patient to do all the exercise in all the direction. We forced the patient brain to accept the functional activity in their daily activity, so that gradually they will increase their exercise and they will be comfortable in doing that particular movement. So this is the way in AMPT. That's why we work on the pathomechanics, because after understanding of the pathomechanics of the patient, we can easily correlate their situation with our protocol. And then for that, because I have mentioned that what we are doing in the AMPT, so I have added here the vision of AMPT for the shoulder. Like we are having the technique, we are having a courses on every topic, whatever the topic: visceral, cranium, somatic, articular, myofascial, neural, vascular, or you want lymphatic, everything, the cranial. Now we are having a full all the things which is explained by the sir in last 3.5 years. We have covered all these topics. Now we are going to correlating all these factors, that as a part of the structure, functional, and the regional interdependence. So in this also, how as a shoulder joint itself what is our vision, how we assess our patient, how we do the physical examination, how we do the evaluation, and how we check the differential diagnosis, that what condition, in which symptom we have to be clarify with the testing. We are not going to do any special testing here. Our special testing is the patient relieving factor, that we check and the patient is getting relief. That is our, for us, that is the real testing which give relief to the patient while evaluation. So that is our priority here. So in this, the first you can see that the surface palpation is our priority, which we do the surface palpation, we check it, and we see that the level, the landmarks which I have already mentioned, that how we check with the acromion, how we check with the coracoid process. So these are the things, their movement, their restriction, that is very much important as a part of our surface palpation. So you can see in this picture itself that how the sir is explaining as a part of the anatomy and the pathomechanics, that every movement, that how we check with the movement, in which direction which joint is moving, either the clavicle is moving, either the coracoid is moving, either the acromion is moving, the scapula is moving. So these movement with the surface palpation is very important to assess. And this is the dynamic palpation, where when we are checking, like we are checking the coracoid process, we are checking the acromion, and we are checking the clavicle joint. So the dynamic movement, that in which direction that joint is moving, so that is known as the dynamic movement. We are checking the joint with the dynamic palpation. That is very much important part here. And we select the position according to the muscle action, because as we are going towards the kinetic part, the rotator cuff muscles, so the all the muscles of the rotator cuff also, and also the muscles which are providing all the movement of the shoulder, that also we select the position according to the muscle. Either the muscle are abductor, either the muscle are adductor, either the muscle is in the flexion group or in the extension group. According to that, we check the muscle action, in which direction that muscle is working. So according to that, we check the working, that which direction is restricted here. And this is the selective tissue tension testing for all the glenohumeral joint ligament, as a part of active movement testing, as a part of our CREX concept, which is very important for the shoulder testing, which as a selective tissue tension, in which direction that tissues are in the tension. So as a part of the active movement, where we explain the patient to do their testing in all the direction, whatever the direction we want to check, flexion, extension, circumflexion. So this is the active movement testing, where the patient itself try to do the active, and that time we check in which direction patient is doing with the painful, or they are doing some compensation, they are doing with the movement. Sometimes they use the cervical spine to the same side. So that kind of the evaluation is also very much important, to see that the where the patient is getting the compensation to doing that particular movement. So that is known as the selective tissue tension testing for that particular joint. And this is the passive movement testing, where the we are going to assess that in which direction either the external rotation is restricted, so their anterior capsule is in the tightening position, or the internal rotation is restricted, so their posterior capsule is tight, or maybe the horizontal abduction is restricted. So these are the things, as a passive movement testing is with the all the movement is also very important. And this is the there are the two situation, the places where we check the passive movement testing in the closed pack position of the shoulder. Because what is the closed pack position of the shoulder? That is the abduction and the external rotation. Here the joint is completely in the closed pack position. So this is the closed pack position of the shoulder, where we check with the passive movement that how much the hardening in the capsule, how the end fill, the end fill is coming because of the ligaments, the internal structure, capsule joints, or the end fill is coming the muscular, the soft end fill is coming with the muscle. So these are the differentiation is also very much important as a part of the closed pack position. And this is the loose pack position, where we check with the external and internal rotation position in the scaption. Scaption is the position where, like with the flexion and with the abduction in between, when we keep our hand, that is the scaption position. So in this caption position, also we check the external rotation or the internal rotation of the arm. So that is also very important assessment of the shoulder patient, because the patient with the shoulder, when the range of motion is restricted, the patient is feel really very much depressed that they are not able to perform their external rotation, internal rotation. They are not taking their hand uh, uh, with on their head, they cannot able to do the comb. So that is very much, or they, if they are not able to wear their clothes, they cannot tie their clothes there with the internal rotation is restricted. So these kind of the mind, the patient is having a problem that when I will be able to perform my activity, when I will be able, or they take, they do like this, so the compensation they take. So these kind of the activity we see in our daily practice, that they are just like here they are easily taking their hand, but there this direction that they are not able to. So how the tightening of that particular capsule, that is not allowing them the external rotation, internal rotation. So that is important assessment. And this is also the position, the muscular and the capsule position, which we check the end feel, that the end feel is the bony end feel, that the capsule is so tight, so it is not going, and the, or maybe the muscles, that abduction, adduction, the muscles, so they are not doing, able to do it. So that end feel in supine position is also, because in supine position the spine is getting in the support of the bed, so that time we can easily perform. But when we check in the standing position, so that time patient is not able to perform their activity. So it means that the patient who is not able to perform their activity in the standing position, so our evaluation and treatment should be in that position, because that position is not allowing them the activity. Because supine they are able to take their both hand into the upward direction, but when they are standing position, so it means the regional interdependence, maybe the lumbar spine, or if they're with the movement they are able to do so, the thoracic spine. So this kind of influence of the regional interdependence also play a very much major role, because some patient, when we do the rotation of the thoracic spine, they are able to move. So it means that there is a need for the thoracic spine, or in the standing position they are not able to do, so it means the lumbar spine which is taking the load in the standing position. So the treatment should be needed, because we know that the muscle fiber, the thoracolumbar fascia, which is coming from lumbar spine towards the hand with the shoulder, that is going, or maybe the latissimus dorsi, which is attached to the thoracolumbar fascia. So these kind of the rethinking is very important part of our assessment. And this is the passive movement testing for capsular, by giving the overpressure for the external rotation, where the anterior capsule, or for the posterior capsule, the internal rotation. So that also very important part of our learning here. This is the loose body reduction technique, because we know that the distraction, when we give the distraction and the rotation for the, so that time the intra-articular structures, which there is a thickening. So after that the loose body reduction is coming, so the patient feel comfortable for their movement. So that also the loose body reduction techniques, we use it as a part of the distraction, and then we do the rotation. So that time the patient feel comfortable, because we have made the space in the interarticular bodies. So after that the loose body is reduced and the patient is able to perform their activity. And this is the deep friction transfer massage for supraspinatus tendon. So that is not only that we are not providing the deep friction, that is not a simple massage which we are going to provide, that is the deep friction massage. For that also, this is a very different mechanism. We cannot just doing the massage. This is, we have to be very careful and clearly that in which direction we are going to, or at what tendon we are going. So activate that muscle and then simultaneously give the deep transfer friction massage, gives relief to that particular muscle which were in the tightness or which were in the spasm. So this is the kind of the way that how we provide the deep transfer friction massage. That is also very important part to how we keep our hand movement and how we give the deep transfer friction massage with the force which is shifted with the shoulder, not with the hand. We are going to give the deep transfer friction massage. And this is Ciriac's manipulation for capsular release by giving the distraction and the thrust. Here also we provide the, we give the thrust, but not like the all the chiropractor we are going to give the thrust. We are having understanding of the pathomechanics. we are having the understanding of the biomechanics that according to the superior, middle, and inferior ligaments of glenohumeral, in which degree of movement they work, according to that, keeping that in that degree, and after that we provide the capsular release by giving the thrust in that particular, going in that position, and then we give the thrust. And this is the capsular stretch also, which as a part of our anterior and the posterior capsule we provide. Here also we have to maintain the stretch, and in the direction where we can stretch taking towards the inferior glide, and then we maintain the stretch for the anterior versus the posterior capsule. So that is also, for that the understanding of full mechanism is needed. Don't think that after seeing this picture you can provide it. For that also the mechanism is very different from where to where we have to keep the hand, and then we provide the thrust. And this is also the anterior capsule mobilization with the distraction. So that is also with the gliding of the capsule with the different ligaments for their neutral versus 70 degree, 1 degree, according to the superior and the middle and inferior fiber of that glenohumeral ligament. In that direction we are going to give, and how we maintain, that is a very much important part of here. And this is capsular mobilization, where the posterior capsule, like in the frozen shoulder, there is a thickening of the posterior capsule. So how we mobilize that capsule, that is important. So don't think that while sitting or wherever the position, you have just giving the, like the chiropractor, they give the thrust. So that is not a right way to give the thrust to your patient. So that will be worsening your patient also. So here also the way is a smooth and the polite way. With the, before going towards the thrust, we have to see the mechanism of for that joint in by keeping in the comfortable position, and then we provide the thrust to that joint. That is the right way to provide the capsular mobilization. And this deep transfer friction massage, according to the fiber of that rotator cuff muscle, like the supraspinatus, infraspinatus, to keeping them in that position, like the supraspinatus, that is in the shoulder abduction. So by keeping hand in that direction, or the infraspinatus, teres minor, so according to in their direction of the movement, in which direction their the muscle work, in that we provide the deep transfer friction massage. And this is Syriax manipulation thrust, which we provide after the mobilization. If there is a need of the last stage of mobilization, that is the grade 5, that is the thrust, then we provide with the distraction and taking to the barrier, and then we provide it. So this was all about the how we provide the techniques as a part of our articular technique, or keeping them in the neural position. And also simultaneously I have not added some myofascial techniques in this because of little time, but definitely we are having not only the articular technique, we are going to use deep transfer friction massage or the neurodynamic position itself, because we know that in the position itself with the external rotation, that how the anterior capsule is tight. So the muscles which are also attached to the anterior capsule, they are in the tightening. So there the myofascial release is needed, or there is the fasciomuscular release is needed, or maybe we can utilize the cup also. We can use the ISTM also. That also as a urgent we can utilize. So there are so many things as a part of a clinician. We are having a full basket where we choose the main technique according to the patient symptom, either the first myofascial needed or the neural component, adding the neural as a part of the anterior versus posterior capsule. Either we have to load it with the radial nerve, we have to load it with the median nerve, so that we decide according to the patient movement restriction. So after that we match their treatment according to articular, myofascial, and neural. And also we add the myokinetic chain, that the chain of the direction which is restricted, either the lateral chain, medial chain, or so according to that. Sometimes the patient who are the oblique chain, sometimes the patient with the right side hip they are having a pain, or the knee, and the left side they are the shoulder they are having a pain. So that time also we have to see that the cross relation with the myokinetic chain, that is also very important part. And also we have to see that the visceral, like the breathing, the pulmo respiratory, so they are the cause of the pain for the shoulder, or maybe the visceral organ like the spleen which is present in the left side, or the liver which is present in the right side. So they need a visceral technique first, and after that the somatic fiber we add. So viscerosomatic, somatovisceral, that is, or the cranial to the cervical spine. We know that the cranial connection with the shoulder, with their plexus, the root values of the cervical versus brachial plexus, maybe the thoracic outlet syndrome. Because of that, the patient is having a pain. So there are so many things which we can correlate with patient symptom by taking their history. Either they are having a surgery before 2 years, so because of that there is a scar on their stomach. So because of that, the scar is in the adhesion. So the release of scar will improve the facial mobility. So these are the things we have to see in every aspect. Then we can treat our patient for the any dysfunction, any disorder, by understanding of all these steps, which is evaluation, assessment, physical examination, and after that the pathomechanics, biomechanics, and in the last is the manual therapy. And then we can give them the better life of our patient. So thank you so much everyone, and thank you so much sir to giving me this opportunity to revise and to learn more and more in depth all the topics, so that when I will be learn from your practical session on Saturday and Sunday, it will be easy for the all the participant also and for me also, so that we can correlate as a part of anatomy and pathomechanics when you will show on the practical demonstration on the subject. So that will give us the clear view of all these things. So thank you so much, sir, and thank you everyone.
You want to change to phone?
No, sir. Now fine.
Okay. So initially I had asked for this some of the questions. I think participants are in a different world. Okay? They are not able to write anything on the chat. So we are ready to close the session.
Yes, sir.
Yes.
Yes, sir. Thank you, sir. Thank you so much.